All right, we're going to end Unit 2 with an ischemic heart condition case. In the note packet, this was originally going to be in Unit 3, but things got moved around a little bit at the last minute. So this is in the note packet for Unit 3 if you're looking for the notes that go with this case. All right, the patient is a 46-year-old female who lives with her husband and 2 teenage children in a 2-story home. She works as an elementary school teacher. She's 5'7" and weighs 278 pounds. She smokes and does not participate in physical activity. She has a past medical history of hypertension, hypercholesteremia, and diabetes. She's currently taking metformin. So as you're reading through these cases, when you're doing your chart review, when you're doing your subjective history, you should be kind of keeping a running checklist of your cardiovascular risk factors. So if we kind of go through this case, age, okay, sex, fine, height and weight, BMI of 43.5. This patient is obese, which is our first risk factor. She is a smoker, and there's no physical activity. So she's got a handful of risk factors. Then if we go to her past medical history, we see she currently is hypertensive, she has high cholesterol, and she has diabetes. So this is becoming a patient who has a very high clumping of risk factors and comorbidities associated with cardiovascular disease. She presents to her doctor due to mild nausea, fatigue, and jaw pain with increased activity. She first noticed it when hurrying to catch the bus, but has started to have similar reactions when walking up the stairs. So she's having symptoms, nausea, fatigue, and jaw pain in response to activity. It was first at a higher degree of activity and is now, she's noticing it in less strenuous situations. So what is this patient describing? Symptoms in response to activity, nausea, fatigue, and jaw pain. This sounds a lot like angina, but it kind of sounds strange, because if you go to the classic signs of angina, we have pressure, heaviness, tightness in the chest or over heart. We don't hear any of these. Pain in shoulder, arm, throat, or jaw. She had the jaw pain. She had some nausea. She had some fatigue, shortness of breath, sweating, and dizziness. So these should be deeply rooted in your brain at this point, that if someone is experiencing any of these in response to increased activity, that's a sign of oxygen supply and demand mismatch in the heart. I just lost the word mismatch, you guys. This is a bad sign. All right, I'm going to shake it off and get this lecture back on track so words like mismatch can come out. Historically, it's rarely the complex science words I lose. It's the very simple words that somehow fall out of my brain when I'm getting 6 steps ahead of myself and what I'm going to say next. This is what I was thinking about that got me distracted. These are the classic signs in men. And our medical reporting and our normative data is highly skewed by data from men. So it is important to remember that for women, classic signs of angina do not include chest pain, heaviness, or tightness. For women, classic signs of angina are nausea, shortness of breath, abdominal pain, extreme fatigue, or pain in neck, jaw, or back, but not often in chest. So because of this, angina and early signs of ischemia are often missed in women. So don't discount it. If they're having, kind of weird symptoms in response to physical activity that go away with rest, this is angina. This is classic angina. So angina pectoris is ischemic pain secondary to mismatch between oxygen supply and demand in the heart. So when you increase demand, there is not enough blood getting delivered to the heart to meet that higher demand. So by far, the most common cause of angina pectoris is coronary artery disease. So in our blood vessels, the innermost layer is endothelial cells. Got the one whiteboard challenge here. This is a little bit of a cheat because I only really have to talk about one thing. But little pathophys review. It helps to keep this all in the same place in our brains. All right, so here is an artery, and the innermost layer is endothelial cells, followed by vascular smooth muscle cells, which gives us a nice thick wall, allows us to contract and relax, to vasodilate and vasoconstrict. And this is all held together by our outermost layer of connective tissue, that is the outer wall of the blood vessel. So very significantly, our endothelial cells release nitric oxide and prostaglandin that basically says, prostacyclin, that says no, no, no to all the blood cells flying by. It keeps the elements of the blood away from the edges of the blood vessel. It protects the walls of the blood vessel. So the initiating event of atherosclerosis is endothelial cell damage. Endothelial cell damage is the kind of common point between all of these risk factors. Because when there's damage, it'll be worse at producing this nitric oxide. You will have less protection in the wall of the vessel. So what can be these initiating events that can damage the endothelial cells? Well, if you have really high blood glucose floating in here, that can damage the endothelial cells. If you have a bunch of inflammatory cytokines, really common if someone has systemic inflammation, which we see in obesity. If you have anything that increases oxidative stress, and a really big one that does this is smoking, can damage endothelial cells. If you have increased LDL or cholesterol, if you have increased pressure, these are all factors that can cause that initiating event of endothelial cell damage. If we look back at our case, this patient fits so closely into this initiating event. Obesity increases the amount of pro-inflammatory cytokines in your blood. Smoking is going to increase the amount of oxidative stress that can damage those cells. Physical activity, when you are physically active, it actually has an anti-inflammatory effect. So the lack of physical activity makes the amount of circulating inflammatory cytokines even higher. Elevated pressure on the walls of the vessel can increase the likelihood of damage to endothelial cells. Poor cholesterol levels in your blood, high glucose in your blood. You can see that this patient has so many factors that each individually can damage endothelial cells and together come together to create kind of a perfect storm for atherosclerosis. So with the absence of nitric oxide and potentially the elevated amount of LDL in the blood, this LDL can work its way through and into the subendothelial region. When the endothelial cells cross, they become oxidized. These are little oxidized LDL. What color should we go here? Without the nitric oxide, your white blood cells, specifically your monocytes, can kind of squeeze their way through here. When they get out of the blood vessel, these are called macrophages that gobble up those oxidized LDL, and now you have foam cells. Foam cells are macrophages that have engulfed oxidized LDL in the vessel wall. So because the endothelial cells couldn't keep the walls of the vessel protected, LDL and white blood cells can move in to the wall. The cytokines released from those foam cells cause the vascular smooth muscle cells to proliferate and to migrate, and they start to move into the vessel area. These are all red blood cells. Excuse me, not red blood cells. What's happening today? I almost feel like I should start over. The vascular smooth muscle cells, excuse me, I'm seeing red, proliferate and migrate, and we see extracellular matrix deposits. So we start to scar this down with extracellular matrix, and we get this big kind of mess of vascular smooth muscle cells, scar tissue, and then right in the center, you get a bunch of free LDL when the foam cells apoptose, and then a bunch of foam cells that are macrophages that have LDL inside of them. And they live inside of this area, which we call the plaque. So we have a lipid core surrounded by vascular smooth muscle cells and extracellular matrix. The reason this is a problem, the reason this causes a problem, first is that it decreases the diameter of this vessel because the plaque moves into the vessel lumen and takes up the space. This wall is no longer reactive to the environment. If you need to vasodilate when you need more blood to an area, this plaque is going to make the wall very stiff and non-responsive. So you're going to see decreased ability to vasodilate due to increased stiffness of the wall. So we have less blood, so the decreased diameter is going to lead to decreased blood flow. And then when you want to increase it with vasodilation, you can't do that because the wall is stiff and the vascular smooth muscle layer has been kind of infiltrated by scar tissue and these foam cells and kind of debris from all the cell death from the foam cells that have died. The other really big problem is that your plaque can rupture. So if I had to say, number one, we reduce diameter. Number two, we reduce responsiveness. Number three, we have the possibility of rupture. And if the fibrous cap that's holding this lipid core in the wall, if it ruptures, the contents of that lipid core spill out into the blood, and this is highly thrombogenic. If it ruptures, it causes clots. The body is going to try to repair the wall very quickly, and you're going to get a spontaneous clot. When this occurs, the clot's going to take up any small remainder of the lumen and can completely occlude the blood flow through this vessel. And this can be an MI, a myocardial infarction. If it's in another location, you could dislodge the clot, and then that would be an embolism. So the ischemia associated with activity is almost always caused by this atherosclerotic plaque that has been laid down in the wall of the vessel, limiting the diameter, reducing the ability of this blood vessel to vasodilate when needed, and leaving this patient extremely vulnerable to atherosclerotic plaque rupture, which would cause a clot. So when you're doing your initial eval, your chart review, your subjective conversation, and you're collecting their risk factors for cardiovascular disease, the more they have, the more likely, especially as they get older, that this is what's happening deep in their vessel. And you can have plaque for a long time without any symptoms. There's no pain receptors here. There's nothing telling you that this has happened until the diameter gets so reduced that you have such a low amount of blood flow that you start to get symptoms. So in general, vessels are almost 70 to 75% occluded before you start to get any symptoms of oxygen supply and demand mismatch. Look at that, mismatch just popped out that time. How do you like that? We can always get better if we just keep trudging along. All right, so that was my little mini review on atherosclerosis. I probably went longer than I needed to because I think this stuff is fascinating. Let's jump back into our case. Okay, so she's got the risk factors, she's got the symptoms. Let's look a little bit more about this myocardial ischemia and how it can happen. So we know what can be causing the restriction in blood flow. Now, why do we end up with supply and demand mismatch? Well, we're going to see an increase in demand whenever the heart is working harder. So when we increase heart rate, when we're squeezing it harder. And when do we see these two things? When we have sympathetic nervous system activation. Oh, which also happens to be the response to our body during exercise. We stimulate the sympathetic nervous system. So we, as PTs, are very often coming in and increasing myocardial oxygen demand. Oxygen supply has to be met by the oxygen delivered in the blood flow. So part of it is going to be the arterial venous oxygen difference, the AVO2 difference. But our myocytes largely extract all of the oxygen that they could use at rest. So when we increase demand, it has to be met by increased coronary blood flow. If we cannot provide enough oxygen to meet the demand, you will end up with cardiac ischemia. If you're not delivering enough oxygen, you can see evidence on the EKG. You can see evidence like T-wave inversions, ST segment depression, be kind of responsive in the moment EKG findings of ischemia. The patient can experience symptoms, and you can start to have left ventricular dysfunction, which would compromise cardiac output. So here is an EKG recording showing evidence of myocardial ischemia. You can see the ST segment depression, both some horizontal as well as some upsloping. I think I've hit you guys over the head with this, but we're really trying to keep tying back our risk factors to the main causes of cardiovascular disease, which is coronary artery disease. So we've hit these all a lot. One thing I want to mention again is if they have other signs of peripheral vascular disease, peripheral ischemia like intermittent claudication, if you have atherosclerosis somewhere in your body, it is likely you have it everywhere because these risk factors are not specific to one part of your body. If you have high blood cholesterol, all of your arteries are seeing high cholesterol. If you have hypertension, all your vessels are seeing high pressure. So it should be a big red flag if they have signs of arterial insufficiency anywhere that their heart is at risk. I also wanted to mention before going on that the number of risk factors is important, both to alert you to the likelihood of some of these negative diseases, but it will also influence their plan of care. So patients may be treated more aggressively if they have more risk factors, and they have a much higher risk of recurrent events if they have more risk factors. So it's both important to help you early identify those that you should be taking vitals on and doing kind of extra vigilant monitoring of, but also that you will see patients treated very differently in the hospital if they're at higher risk for recurrent events. They might opt to do a surgical intervention earlier or a more aggressive treatment than someone who maybe just has one risk factor. They might do a little bit more of a wait and see approach before jumping into some surgical options. So just something to put on your radar. I also added Prince metal angina into this lecture just to remind you of one of the other kind of main types of angina. This is different than pectoralis angina because Prince metal angina is caused from a vasospasm. So the vascular muscle cells within the wall of the vessel are over-constricting, and that's what's limiting the blood flow. So sometimes this is called atypical or variant angina because the word angina has become synonymous with angina pectoris. So to kind of really highlight, this is a different one. Sometimes they call it variant or atypical. Unlike angina pectoris, this is not associated with exertion. So this is not in response to activity. It more often than not occurs early in the morning, and these patients typically do not have classic cardiovascular risk factors. So this is a very different presentation and a very different patient. They would typically be treated with calcium channel blockers. Calcium channel blockers, as a quick little farm reminder, they end in a pine for all their drug names. That helps you remember where you are. They block the calcium entry into a muscle cell. So muscles require calcium for their contraction. So in a blood vessel, in a vascular smooth muscle cell of a blood vessel, if you decrease the amount of calcium, you will decrease the strength of the contraction. So this would cause vasodilation. So by using a calcium channel blocker, you can increase coronary blood flow. So when you're thinking about the blood vessels in the heart, that should make sense. But this is also going to affect blood vessels in the periphery. So if you get systemic dilation, you can decrease the afterload on the heart and make it easier for the heart to pump into. This can also have effects on reducing preload, as you won't get as much of the constriction on the venous side. A third kind of action is it does decrease calcium release within the myocyte, so it would decrease the strength of the cardiac contraction, but this is not normally seen as the primary benefit of the calcium channel blocker. Some calcium channel blockers can also alter cardiac excitation, so it can change electrical activity within the heart. So sometimes you can see disturbance in cardiac rhythm as a side effect with the calcium channel blocker. When it comes to exercising, some with calcium channel blocker, it is safe to exercise, but you may see lower exercise heart rate and BP. So you'd want to utilize the Borg for your RPE. And then just be really aware of those vasodilatory effects in the periphery, because exercise is going to cause vasodilation, and they have a drug on board that makes more vasodilation. So this can lead to hypotension. And then if you think about it, if you're doing exercise in a hot environment, this can even further exacerbate these effects. So if they're exercising and they're having any dizziness or they have a fainting episode, that is a negative response, probably related to the hypotension. So conditions that are commonly treated, coronary artery disease is a big one. Calcium channel blockers are involved in that supraventricular tachycardia. We mentioned in the Arrhythmia case that the calcium channels are so important for the spontaneous depolarization of the SA node, that when you're having supraventricular tachycardia, when the origin of your tachycardia is above the ventricle, this is a good drug because it can slow the depolarization of the SA node and decrease heart rate. So it's good for that arrhythmia. It's good for hypertension because it's got that nice vasodilation. And then Raynaud syndrome, again, if you remember, is the spasming of the blood vessels in the fingers. And so this would block that vasospasm. All right, that was a little aside with princemetal angina. It didn't really fit anywhere else in this course. It didn't really deserve its own whole case. So I just wanted to touch base with you guys on that kind of variant angina. So for our patient who had a long list of risk factors and was experiencing classic signs of angina for a woman, she was put on statins, a beta blocker, and nitroglycerin tablet sublingual as needed. So statins are brought on board to help lower their LDL. The beta blocker we've already talked about, and the nitroglycerin tablet is basically like a nitric oxide donor. It is a vasodilator, so it can reduce myocardial oxygen demand. It does this in a big way by doing venodilation, so you have less preload getting back to the heart. It also dilates arteries, which is going to decrease afterload. And then if you can get those coronary vessels to dilate, you can increase coronary blood flow. The adverse effects are largely related to kind of the hypotension and the vasodilation. that comes from the med. So much like calcium channel blockers, when someone's on nitroglycerin and they're exercising, this may cause more than normal. This may cause hypotension, I should say. This next point is a big one. If you have a patient who uses nitroglycerin when they experience angina, they have to have this medication with them during therapy. And this can play maybe more of a role in an inpatient setting, where if they're going into like an inpatient rehab gym and they're leaving their room and going to the gym for therapy, they might not think to bring medications with them in the hospital. And if they have a ischemic episode in the gym, they need to have their drug with them. More often than not, in an outpatient setting, patients would have it. So it's more that kind of unique patient that's moving around in the hospital. But if that's how they are controlling their ischemic episodes, then they have to have the tools with them. So this is kind of a common question that we get, kind of, when is it serious? So if you're doing exercise with a patient and they experience angina and they have nitroglycerin, they should take their nitroglycerin tablets. If they have taken 3 and they're still having symptoms, you should call 911, because that should have terminated the attack by that point. So this patient had been taking her medication regularly, but she was reporting an increased incidence of ischemic episodes. She was now having these symptoms when walking from her car into school, so her cardiologist orders an exercise stress test with myocardial perfusion scan. So the exercise stress test is the best non-invasive test to diagnose and manage coronary artery disease. That being said, it is less sensitive and specific for women. For whatever reason that is not well known at this time, women may not demonstrate as much of a significant response to a stress test as a man. So the overall goal of the test is that you systematically and progressively increase the oxygen demand of the heart. So you make the exercise kind of progressively harder during the test. And then you carefully evaluate the response to the increased demand. The mode of exercise that's used can vary. It really depends on the facility and the patient's abilities and preferences. Bikes can be used. They sometimes are a limiting factor because patients may experience leg fatigue before they experience kind of cardiopulmonary maxes. So it's like a muscle thing that stops them before their heart. The treadmill doesn't have that issue, but then they're harder to monitor on the treadmill. So there might be a reason that they pick one over the other. There's a host of protocols that can be used. It's pretty much standardized by facility. So you can do an exercise stress test to the max. That would mean that the test would end at the patient's predicted maximal heart rate, or if they have symptoms. So symptoms would be the patient's perception that they're unable to continue, shortness of breath, leg fatigue, chest pain, any of those things. You can do an exercise stress test as a submaximal test. With a submax test, there's a predetermined endpoint chosen. So once they get to 75% of their heart rate max, or once they hit a certain workload, most tests are symptom limited. If a patient's having an exercise stress test, there's a reason, and it's typically, it will bring out those symptoms, and that is what will kind of dictate the end of the test. So this kind of laundry list is in your notes of all the times that you might see stress testing. It's very good for monitoring coronary artery disease or figuring out kind of atypical chest pain. It's really important after a surgical intervention to evaluate arrhythmias and a whole host of other things. So it's a pretty common assessment. So you can have your cardiac system stressed with exercise, or you can do a pharmacological stress test. So a pharmacological stress test induces a physiological stress, but in the resting position. So this would be used in individuals who can't perform an exercise stress test, or when they did the test, they couldn't achieve at least 85% of their predicted heart rate max. So they couldn't get the heart rate high enough to truly know if they stressed the heart. And this can happen with patients who are on meds like beta blockers. So for a pharmacological stress test, they use a pharmacological agent to do the stressing. So the patient's in the resting position, they inject the med, and then they monitor the response. So I think I have these in your notes. These two top drugs, adenosine and dipyridamole, are coronary vasodilators. So they try to maximally vasodilate the coronary vessels and see what happens. Dobutamine is an adrenergic stimulant, so it's very much like exercise and increases myocardial oxygen demand. And then Lexiscan increases blood flow to the coronary arteries as well. Sometimes they'll do a pharmacological stress test at the same time as like a echocardiogram or MRI or CT scan, because during these tests, then they wouldn't need to reposition the patient. They wouldn't need to have them like get off the bike really quick and get into the scan. They can just do it all at once. So that's another time that you might see a pharmacological stress test done. So this is a wordy slide. I don't like reading slides to you, but I wanted to make sure this was in your notes. And these are really the criteria that dictate a poor prognosis if someone did an exercise test. So remember, they're increasing the exercise demand or the myocardial oxygen demand if they induce ischemia during an early phase of the test. That's a very poor prognosis. So on the EKG, you see evidence of ST segment depression in one of the earlier phases. The greater the magnitude of the depression, the worse the prognosis. So they will observe changes in the ST segment, and then they will also look at how long it takes for that segment to come back to normal. The longer it takes, the worse the prognosis. If there isn't any deviations of the ST segment, but the max heart rate achieved is much lower than predicted, that can be a very negative for prognosis purposes. And if they have angina, this like symptoms of angina with ST segment depression, that nearly doubles their risk. So that's a very negative finding. Good findings of an exercise stress test is that they can exercise for more than 6 minutes if their maximal heart rate is above 150. And if they do have deviations of the ST segment, it comes back to baseline in less than a minute. These are very positive findings on an exercise stress test. An additional test that could be done is a myocardial perfusion scan. What they do here is they use radioactive nuclide perfusion imaging, meaning they inject you with a radioactively labeled agent called a tracer. This agent would get taken up by the myocardium in proportion to the blood flow. So during an exercise stress test, in about the last minute or so to go in the test, they would inject the tracer. So at that time, you should be having, a lot of blood flow to your heart because you're near maximal in your exercise capacity. The tracer circulates and the myocardium will pick up this tracer out of the blood. So anywhere that's getting a lot of blood flow should pick up a lot of tracer. So when they, immediately after the exercise, they're going to scan the patient. In order for the tracer to get picked up and then light up on the scan, the cells must be first perfused, blood flow has to be going by them, and two, the cells have to be metabolically active. They can't be dead because they have to they actively take it up. So there's some common agents listed in your notes. As soon as the test is done, they scan, they look to see which part of the heart lights up. Then they would repeat the imaging 4 hours later because they're looking for kind of any viability in the tissue. So if there are cells that are non-perfused and not alive, they would be kind of quote unquote cold spots on the scan. They wouldn't light up. If you had a cold spot immediately following exercise And then when you repeated the scan 4 hours later, it still did not light up. That would be considered irreversibly damaged tissue. It became ischemic during the exercise, and it never picked up that dye, even with 4 hours of kind of letting the blood flow by it. If it was a cold spot immediately at the time the stress test ended, but 4 hours later it was reperfused, meaning that that tissue took up the tracer, this is a reversible ischemia. This is the type of heart that would benefit from an intervention. So you don't want to put a patient through like a CABG, for example, a coronary artery bypass graft, to send blood to a portion of the heart that's dead, because it doesn't come back to life. Those cells are gone for good. But if you do the scan and they're not getting blood during exercise, but there's any blood flow going to them and they're alive enough to pick it up, that would be ideal tissue that would respond to a CABG or some of the other interventions. So our patient tolerated the exercise stress test well, but did experience episodes of angina associated with ST segment depression. The scan revealed focal areas of reversible ischemia in the anterior and septal aspects of the left ventricle. From these reports, she was diagnosed with a left anterior descending artery blockage. So it's good to be familiar with the coronary arteries and which sections of the heart they perfuse. So your right coronary artery perfuses the right atria and right ventricle, and it does get to the inferior wall of the left ventricle. The right coronary artery in most patients perfuses the AV node, but it's about 50-50 for the SA node between the left and the right coronary artery. So that's there's no way to predict that one. The left coronary artery bifurcates into the left anterior descending, which kind of gives its name away. The anterior descending perfuses the anterior wall of the left ventricle. And the left circumflex kind of wraps around. So you hit left atria and the lateral and posterior walls of the left ventricle. And again, about 50% of people would get the SA node perfused at this point. Coronary arteries have this unique structure to them where they can have anastomosis or intercoronary channels, where you see mixing of blood from two primary sites. So between arterial branches, there's collateral circulation. This is really important for patients suffering from coronary artery disease, because if their left anterior is blocked, and they could actually get blood flow from the right coronary, right? The right coronary can come down and actually perfuse over. That can help possibly to salvage some tissue, or maybe you could even develop additional kind of collaterals between them. That's a little dramatic. That's a little macro for how it would be, but that's kind of the point. The other important thing to remember with coronary vessels is these arteries are feeding this vast capillary network. And it is an extremely dense capillary bed. On average, myocytes have about 1 capillary per muscle cell. So that's an incredible amount of surface area for gas diffusion to take place. This is part of the reason why cardiac hypertrophy can get patients into ischemic trouble pretty quickly. When you have pathological cardiac hypertrophy, the capillary network does not enlarge at the same rate as the heart. So where at rest, you might have 1 capillary per myocyte. In cardiac hypertrophy, the muscle cells grow and the capillary networks just don't keep up. So there's a much further distance for oxygen to diffuse to get to the larger heart cells. Just something to keep in the back of your mind as a little reminder from PathoPhys. So this patient who had the signs of angina on her scan was ordered to have a percutaneous coronary intervention, PCI. PCI is just a big umbrella term for when you use like a peripheral vessel to do a coronary intervention. So from the periphery, they're going to do a percutaneous transluminal coronary angioplasty with stent. That's a very long name for what you probably are more commonly used to hearing as an angioplasty. So for all of the interventions that utilize a peripheral vessel for coronary intervention, there would be a catheter that enters under fluoroscopic guidance through a peripheral access route. It's typically either the femoral or radial artery. And they feed that through until you get to the coronary arterial tree where the occlusion is located. So at this point, you could do an atherectomy, an angioplasty, stenting. Atherectomy, I'm not going to talk too much about. It is what it sounds like. It is cutting through and excising an atheroma, which is the fancy word for plaque. There are times when this is appropriate and necessary, but it carries a lot of risk. There is about a 4 times increased risk of perforation when you're doing an atherectomy, when you're actually cutting the plaque out. And there's a 9 times higher risk of vasospasm. So it kind of irritates the blood vessel to the point where it almost pinches off flow. So it comes with risks. So that one's not done as common, but there's times when it might be warranted. Angioplasty and stenting, though, is incredibly common. Of all the angioplasties done, about 90% of them include stenting. When somebody gets a stent placed, it can be either a bare metal stent or a drug-eluting stent. So, as a reminder, an angioplasty is a balloon-tipped catheter that's inserted, and this would be the site of occlusion. So you can kind of see that in the cartoon, the yellow is supposed to be the plaque that's in the wall. The balloon gets inflated, which basically compresses the lesion, pushes it outward, kind of smashes it into the walls, and then the balloon is deflated. And if there is no stent, that's the end. The balloon is deflated and they pull it out, and fingers crossed that the plaque doesn't just sort of move back in. Because there's a frequent recurrence rate when it's just an angioplasty, they typically do an angioplasty and stent, where a stent is this tiny mesh-like scaffold that's placed within the lesion to increase the luminal diameter. Now, this is metal that's being put inside of our bodies. So our body has a tendency to form scar tissue or thrombi around an inorganic material that's put into our body. So because of that, the stent itself can sometimes be the cause for the restenosis. So that is where this drug-eluting stent got popular. They coat the stent with anti-proliferative drugs, and that decreases the restenosis risk. Regardless, after this procedure, patients are still going to be put on a round of antiplatelet therapy to decrease the risk of thrombi around the stent. It is typical to see a dual antiplatelet therapy for about 12 months after an angioplasty and stent. So this patient tolerated her angioplasty well, and she was put on the dual antiplatelet therapy. So she was given aspirin and Plavix. So both of these drugs are working to prevent platelet aggregation. They work at different places, right? Aspirin is a COX-1/2 inhibitor, where the Plavix works at the ADP. They both carry an increased risk of bleeding, but it is a risk-benefit analysis. When you've put in a stent, there's too high of a risk of clot, so it's worth the risk of a bleed. So the patient was put on these meds, and she was discharged the next day. 4 weeks after her intervention, her angioplasty, the patient suffered a small hemorrhagic stroke. She was treated at a local hospital where they discontinued all of her anti-clotting therapies, and the patient recovered well from her neurological impairments. But her angina symptoms returned and progressed. The patient described anginal symptoms with minimal activity and occasionally even at rest. She used to be able to reduce symptoms with 1 nitro tablet, but she is now taking 3 and the symptoms are not fully subsiding. So this is a really tricky patient. Because of her history of the stroke, she is not going to be a candidate for any kind of surgical procedures right now. But her angina is getting significantly worse. So they have to do something because she's not even able to get her symptoms under control under 3 tablets. But surgery could be really dangerous for this patient. So for that reason, her cardiologist ordered enhanced external counter pulsation, EECP. So EECP is a pretty cool intervention. They put a series of pneumatic cuffs around the thighs and calves. And the goal is that this is a non-invasive method for raising diastolic blood pressure. So when you increase diastolic blood pressure, you can increase coronary blood flow by 20 to 40%. So the heart contracts during systole, the heart rests. The cuffs on the outside of the legs compress and raise diastolic pressure, creating retrograde blood flow in the aorta, which kind of floods the coronary vessels with blood during diastole. Now, we haven't hit it in this class yet, but I'm sure some of you are familiar with the intra-aortic balloon pump. So this is basically using the same theory behind the invasive intra-aortic balloon pump in a non-invasive way. So they synchronize the inflation of the cuffs with the cardiac cycle. So during diastole, there is a compression, and it starts at the bottom. It goes up, up, up to try to increase diastolic pressure and retrograde flow. Then during systole, the cuffs relax, they deflate to allow the blood flow through during systole. As systole ends, you squeeze from the bottom up until you raise diastolic pressure, creating retrograde flow into the aorta. So this is non-invasive. You can do this as an outpatient. Here is someone receiving EECP. You do 1 to 2 60-minute sessions 5 days per week. The treatment totals 35 hours altogether. The reason this is proposed to work is that the rush of blood through the coronary vessels actually stimulates the growth of new collaterals. What they have found in response to EECP is large caliper collaterals on the epicardial surface. So the patients are actually growing collateral vessels between their larger vessels, not just at the teeny tinies at the capillary junction. We're talking about arterial anastomosis. This is developed in response to the flow-induced pressure and the chronic ischemia. This is a very similar theory as to why someone who has chronic angina will tolerate an MI much better than somebody who gets an MI from like an embolism, because the angina they were experiencing for months or years was actually stimulating a similar growth. So the benefits that are observed in response to EECP have been reported to last 5 years. So non-invasive has the effect of increasing blood flow through the formation of collateral vessels that has a long duration benefit. So our patient tolerated this treatment well. She reported reduced incidence of anginal symptoms, and she is now able to participate in all ADLs without symptoms. She still requires her nitroglycerin tablet for increased exertional activities. So this was a case of somebody who received a pretty low-risk intervention with her angioplasty, but the medication required afterwards to manage the risks associated with the stent was really the cause of the hemorrhagic stroke. But then once she's had the stroke, she kind of no longer qualifies for other interventions for her heart that would be more invasive. So patients can get, into these sticky spots when they no longer would tolerate the treatment that would work the best, and you have to kind of work around the margins and find what is best for that patient and still safe for their overarching kind of medical needs. All right, this will be the last lecture for Unit 2. We will pick up case number 18. I know in your notes it's all on the same page, so you might want to just draw a big line at this point. We will start the next case with the Unit 3. We'll start all the other ischemia-related and heart failure patients in Unit 3. Thank you for your attention, and good luck on your test. Bye.